Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Meaningful Use 2016 Challenges and Change call. Please note that all lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Jane McGraw. Ms. McGraw, the floor is yours.
Thank you very much. Good afternoon, and thank you for participating in our webinar, our Learning in Action Network webinar this afternoon. The webinar is presented free of charge from the Lake Superior Quality Innovation Network, which is comprised of the Medicare Quality Improvement Organizations from Minnesota, which is Stratus Health, Michigan, which is MPRO, and Wisconsin, which is Medistar. Today's presentation is being recorded and will be posted to YouTube. You will be able to access the recording by going to the Ellis Quinn website, Meaningful Use for Health IT webinars section. This will probably be up within about 7 to 10 days after the webinar. During today's presentation, as the operator indicated, all participants will be on mute. We will open up the lines at the end of the session for an open question and answer period, but we would highly encourage you to submit any questions that you have on the chat in the right-hand corner of your screen, and we will be monitoring that throughout the presentation and asking some of those questions to our presenters to be able to respond them on a timely basis. Also, at the end of the webinar, you will be given the names of contacts at Medistar, Minnesota, and Michigan, and you can contact them after the presentation with any additional questions that you may have. The PowerPoint Modified Stage 2 worksheet was made available to you as a download as you were signing into the presentation, and you can access that at any point in time, either during or after the presentation. We are very excited to have two Meaningful Use subject matter experts who have been involved in the Meaningful Use program since its beginning, Dr. Lisa Gall and Reed Haza. Dr. Lisa Gall is duly certified by ANCC as a family nurse practitioner and nurse informaticist. She completed her MSN at Concordia University in 2004. She attended the University of Minnesota, completing her DNP in 2010 and Leadership in Health IT certificate in 2011. She brings over 30 years of healthcare experience in nursing and administration and has been a family nurse practitioner for 12 years, 8 years in rural family practice and 4 years in the ED and urgent care. Lisa has been an HIT consultant for the REACH program, the Regional Extension Center for Minnesota and North Dakota, since 2011, and is now working full-time at Stratus Health as a clinical program manager, working on local, regional, and national projects related to practice, quality, and health IT. She is well-versed in Meaningful Use, MACRA, and MIPS, has assisted multiple organizations in attaining meaningful use, and has performed EHR efficiency analysis and optimization projects in clinics and hospitals, and led HIE and change management across various care settings. Lisa's interests are focused on using technology to engage patients and mobilize providers and care teams in using data and technology to improve care, quality, and care coordination across the continuum of healthcare. Reed Haza is a healthcare IT consultant and project manager based in Minneapolis, Minnesota, with an MA in Health Information Management. His current work, along with Meaningful Use support, includes efforts to identify and connect patients with prediabetes and hypertension with community resources through the Minnesota State Community Wellness Grant. He has also recently worked with a group of hospitals in northern Minnesota to adopt and implement healthcare analytics software to initiate an accountable care organization style of data sharing and care planning interventions. He has provided guidance to clinics using the assess, plan, select, implement, and optimize methodology when adopting electronic health record systems. Reed has worked with REACH, the Regional Extension Center for Minnesota and North Dakota, and at Stratus Health from 2011 through the present day to guide clients through all aspects of the Meaningful Use program. Several regional organizations have invited him to speak at their annual conferences on the topic of meaningful use. He has also been engaged in the Health Information Exchange, privacy and security reviews, as well as state-level implementation and support of meaningful use through the Minnesota Medicaid EHR incentive program. I will now turn it over to Reed, who will begin the presentation.
Okay, well, we can start off here. Just wanted to make one quick comment about the organizations participating and supporting today's call: MPRO in Michigan, Stratus Health in Minnesota, and Medistar in Wisconsin. And those are the three entities that make up the collaborative Superior Innovation Network. So again, glad to have you all today, but we're going to get right into it because we've got a lot of ground to cover. We've got a short slide here on the objectives. We'll talk initially about the current state of the Meaningful Use program and give a little bit about the background and some expected upcoming changes. And so we'll spend a few slides on that. We'll also have an overview by Lisa of a Meaningful Use Objectives and Measures summary tool. And then we'll go point by point through some of the most challenging meaningful use objectives that folks are currently engaged in, including the Health Information Exchange, e-summary of care, also known as the Transitions of Care, the Medication Reconciliation Objective, Patient Electronic Access, also known as View, Download, and Transmit, VDT, and Secure Electronic Messaging. And then last but not least, as there's a lot of territory to cover on this one objective, Lisa will talk about the public health reporting, specialized registries, and then we'll hopefully have a few minutes for Q&A. So, moving right along here, I'm going to talk about the current state of the Meaningful Use program, but talk a little bit about where we've been. So if we kind of mentally roll back to 2011 when the program started the initial years of Stage 1, we had 2011, 2012 there, and then we had an extension of that Stage 1 into 2013. Now, everybody didn't start in 2011, so there were a few entities that got started early that did 3 years of Stage 1. And then we had the announcement that Stage 2 would be delayed. And in 2014, we had the interesting aspect of a shortened year because of that certified EHR technology introduction known as 2014 CERT. And so we had folks switching over from the initial 2011 certified technology to that new version. And then last year, 2015, we find ourselves in the continuation of Stage 2, but also the later announcement at the end of the year of modified Stage 2 final rule, which actually didn't come out until October 16th. That was when it was published in the Federal Register. And at that point, it was late for some folks who were anticipating that to get up and running and do their 90-day period. So as part of that modified Stage 2, it was kind of a consolidation of a number of objectives and measures into single objectives with multiple measures in them. We saw a longer list, for example, going from about 18 down to 10 for the EPs, and a similar count for EHs comes in at 9 total objectives and measures for this new modified Stage 2. Along with those changes in 2015 that are now continuing to be in effect for 2016, we also had the introduction of payment adjustments that started at the outset of 2015, and those have that 2-year look back, if you're familiar with that. So for those who participated in meaningful use in 2013, they didn't incur the penalties or payment adjustments in 2015, and that's true for 2014, for then payment adjustments in this year, 2016, and then moving forward. So last year, as you have attested to that, that will enable you to avoid those 2017 payment adjustments that start at the outset of the 2017 calendar year. So we also have upcoming here the Stage 3, which is optional in 2017 and will be mandatory in 2018. And with that, we'll see some additional modifications to the program. What we do know is that Stage 3 it came out along with the modified Stage 2, but interestingly, there was a commentary period that came out along with that, and so CMS is still seeking input on that. We'll see a new final rule for the program, and I'll get into that in just a moment here, that will be talking about MACRA and MIPS, and along with that, some additional modifications to meaningful use in the upcoming years. But most importantly, the big news that came out of last year about April was the announcement of the Medicare Access and CHIP Reauthorization Act of 2015, also known as MACRA. And with that came three major announcements. And number one was the end of the sustainable growth rate formula, and that was to be replaced by this program known as the MIPS program, or Merit-Based Incentive Payment System, and the alternative payment model. So you ended up with two tracks here, and you'll have to make the decision in the coming years as to which track you'll want to take advantage of. The MIPS track includes meaningful use, PQRS, value modifier, whereas the alternative payment model is more of those choices that are ACO-like. But either way, the focus is kind of consolidating these programs under these two different tracks and rewarding better care for outcome-based measures, looking at quality measures, and many of those measures are already part of the clinical quality measures in the Meaningful Use program or part of PQRS, but those measures will also be part of the alternative payment models. So, to break down the MIPS program, again, I mentioned the three components there, the physician quality reporting system, value-based modifier, and the Medicare electronic healthcare record program. So, with the announcement of this new legislation coming out later this year, we'll have more specificity as to what's going to happen there. But one comment I would make with the MIPS program is what ends up happening there is that the combination of these multiple programs into one will ultimately result in a single composite performance score of 0 to 100, and the basis for that are four components of quality, resource use, clinical practice improvement activities, along with meaningful use of EHRs. So that's a lot there. We could spend well over a full hour just talking about the changes in MIPS and ACRA, but be familiar with those terms as we'll have some decisions to make coming up. So I'm going to hand this over to Lisa, and she'll talk about the Meaningful Use Summary tool.
Thanks, Reed, and thanks, Jane, for the introduction. So we developed a little tool that just kind of goes over all of the modified Stage 2. We're going to overview the objectives and measures of the modified Stage 2 final rule released in October. This view includes what's expected for 2016 and 17, but not for 2015. The modified Stage 2 meaningful use includes 10 objectives for EPs and 9 for hospitals. I will point out the key on the bottom first. The black text includes both EPs and EHs. The brown text represents EPs only, and the blue text is for EH and critical access hospitals only. The red text, anything in red, shows an increase or change from previous years. So the objectives on the left column are listed, 1 through 10 for eligible providers, 1 through 9. I still left them numbered as 10 for eligible hospitals. Some of those objectives have more than one. For example, item number 3.1, 3.2, and 3.3 has measures for medication labs and radiology. The second column is the objective heading, and the third column defines the measure within the objective. I know this is very small print, but you will be able to access these Excel files that were sent, I believe, to each of the participants, or nope, they're accessible. We'll talk about that in a short while on where they're accessible. The fourth column clarifies if there's an exclusion available for the objective or a measure, and the fifth column shows that there's an alternate exclusion available, and that is only as an effect of modified Stage 2 rules. The sixth and seventh columns show the threshold required in 2016 and 2017, and do note that if you meet the threshold and also qualify for alternate, you can choose whether you report on the measure or report an exclusion, alternate exclusion. Finally, two measures encompass some of the measures that were dropped from the previous Meaningful Use Stage 1 and 2, the HIE and patient access. And those two measures, here, list number 1 shows the required elements for Objective 5.1, E-Summary of Care, and these elements should be on your CCD. The second list shows the required elements for Objective 8.1 patient electronic access and should be available on your patient portal. However, all the checked items are required, but they can be omitted at the discretion of the provider. And then Reed will go into more detail on e-summary of care in the next few slides and later for e-access.
Okay, so now Lisa and I are going to do a little tag team handing back and forth talking about individual meaningful use objectives and measures, and we're going to start off with health information exchange, also known as e-summary of care, or the transitions of care. And for each of these objectives, we have a little screenshot from the specification sheets. For most of you who've been with Meaningful Use for a number of years, these specification sheets are quite familiar, and they state the objective, the measure, and sometimes there are multiple measures here for each objective, and the exclusions. So in this case, we have the transitioning of a patient to another setting of care, and then using your certified EHR technology to do that for at least 10% of those transitions of care and referrals. So what is the summary of care? If we kind of mentally go back to the previous slide where Lisa was showing the list of the components that have to be on the summary of care, there are 16 demographic and clinical elements, and as long as those are available in your cert and being documented, as Lisa said, those need to be included as part of that continuity of care document. And there are 3 that are required: the problem list, med list, and medication allergy list, unless there's a reason to clinically withhold that, and that's valid too for any of the other 16 components there. So when you're considering sending the e-summary of care, you're asking yourself, well, what is available to do that, or what's the conduit or the transmission method? And most of us are using the direct methodology, which is a secure email, basically, and some folks have that embedded in their EHR system. There's another sort of transport protocol, if I can put a technical word to it, that allows you to send that message, and it, again, depends on your vendor. Is that technology built into your certified EHR technology? Some of us are able to send those direct messages, for example, directly from the EHR, don't have to navigate outside of it. Others are using vendors that require you to go to a secure website in as much as you would do a Gmail or Yahoo Mail or something, but it's HIPAA compliant and secure and allows that message to be protected there along with the attachment, that CCD. One of the critical things about this is thinking about who your trading partners are, and by trading partners, that you're referring your patients to. For this year, we know 2016, we're doing a full year measurement period, unless you're new to the program or just starting off in meaningful use. And there are those cases of new providers coming out of med school, or, for example, in the Medicaid side of the program, it's very common to be starting the program a little bit later than Medicare participants. But ultimately, you really need to think about who those people are, or what entities you're doing the referrals to, and making sure, as you look at your measures, that you're hitting that 10% threshold. One of the challenges that we've encountered with this HIE objective is determining what those direct addresses are. Each state has its own solution, and I'll touch on that in a moment as to how HIE is conducted within the state, whether it's a public-private cooperation, whether it's a single state solution being implemented and governed by the state. But overall, one of the things is that the direct addresses are contained within that vendor technology, and the challenge is sharing those outside. If you're referring to somebody else who's using a different HIE vendor, you may need to keep up a current list and determine what those addresses are. It could be as simple as contacting that hospital or clinic and asking them what that direct address is, but then there's the management of it. One of the other things that you need to think about is that that message needs to arrive with reasonable certainty, and that's bolded there in the wording to make sure that it is indeed arriving there. When we can think back of, when faxes just came out and we had to pick up the phone and call every time to make sure that it did arrive. So that's not untrue sometimes as we get into this new HIE method of sending things. Can you confirm that it actually arrived? Was it open? Was it read? What are those workflows that you have in place to ensure that? And also on the receiving end, it's important to know, is the direct address going to an individual provider? Is it going to an organization? Is it going to an email pool so multiple people have access to that? So there's some of the things that you might want to think through. So for the purpose of the Lake Superior Quality Innovation Network, Michigan, Minnesota, and Wisconsin, here we have examples of 3 states with 3 different approaches. In Michigan, the HIE out there is made up of 8 qualified data sharing organizations, or QOs, and that is known as the Michigan Health Information Network of Shared Services, and there's also Health Information Services Cloud, which is part of that. In Minnesota, we have a different approach where we have 2 entities. One could either be a health information organization that's kind of a higher level, one that's doing shared services and so forth, or a health data intermediary, of which there are currently 13. And those are organizations that are really providing the conduit or the direct messaging capability. So we have a sort of a public-private cooperation where there's certification required by the state for entities, those HIOs and HDIs that operate within our state borders. In Wisconsin, we have something a little different here, known as Wired for Health, which is a state HIE plan, and Wishin is the cooperative that has governance over that. So more of a single solution for the state of Wisconsin there. So multiple avenues, but all ultimately trying to accomplish the same thing. So I'm going to hand it over to Lisa, and she'll talk about medication reconciliation.
Okay, so thanks, Reed. Sorry, I'm kind of just getting focused here. The medication reconciliation objective is one that apparently seems rather simple, but and straightforward, but it does have a few nuances to it that, have been a little confused and have recently been more clearly stated in the most recent specification sheet by CMS. So as you see on this spec sheet, the EP and EH must perform the MedRec for 50% of the patients who are transitioned into their care from another setting or believes an encounter is relevant. The exclusion is that no patients are transitioned into your care from any other setting or you've had no new patients. Not or, just and. Explaining this a little, the 50% medication reconciliation requirement refers to patients transitioned into your practice and any new patients. And the CMS specification wording of that is the movement of the transition of care is the movement of a patient from one setting of care to another. And CMS goes so far as to define new patient as a patient never seen by the provider. However, the provider may use an expanded definition of new patients, such as the inclusion of patients not seen in the past 2 years. So you want to make sure you have a policy regarding that and make sure that you know how your EHR is actually tracking this. And I think this is where organizations have actually gotten a little confused with that because they're not counting the new patients, and the new wording in the spec sheets is very specific to new patients.
So Lisa, there's a question on the chat that says, what if the patients were not transitioned, in quotes, into care from another facility?
So the best practice that we've seen out there is that patients who are seen in your clinic have a medication reconciliation. And the reason is you don't know if they've seen another provider. And so, technically they may not be transitioned into your care, but they could indeed have had medication changes or new medications added without your knowledge. And without doing a medication reconciliation, you wouldn't know that. Okay, I'm going to hand this over to Reed again. Tag, you're it, Reed.
Okay. So I'm going to speak to a couple of objectives. One is going to be the patient electronic access, more commonly known as View, Download, and Transmit, or VDT, as well as secure messaging. And here again, this is going to be a little bit small to read, but we see the specification sheet for that. But I'll walk through the individual components or measures of this particular objective. So we know for the first measure here, 2016 and 2017, it's about providing access to 50% of unique patients. And here, the unique thing about this is simply you've provided access. So most commonly, that will mean that you've given them a login or user ID and password. And if you were to look at the detail of the specification sheet, the patient basically needs no further interaction or assistance from your clinic or from your hospital to accomplish that. So basically, this is just setting up your portal, providing access. The patient has the capability to do it, but not actually measuring whether they've done it or not. The second measure, however, for 2016 is that one patient, quite a low threshold, actually does indeed accomplish the view, download, or transmit. For 2017, that jumps up just a bit to 5%. Well, that 5% can actually be a large 5% in some cases because of the barriers that we're encountering. So while I've got a bullet point here that mentions the patient portal and secure messaging being kind of similar objectives, similar insofar as CMS doesn't really call it out as a patient portal in the specification sheet, but really many of these objectives point to the use of a patient portal. What are some of the barriers that we're encountering? Well, of course, many times elderly patients may not be able to access that. You may have non-English speaking patient populations. So what are solutions for those? Of course, you can have a proxy, or in the case of an elderly patient that may not be able to accomplish that, having their patient do it on their behalf, parents doing it for their minors. And basically what CMS says in the specification sheet is that an authorized representative is able to go in there and access that on their behalf. So that was something discussion you most likely have with that proxy or other family member. You know, a little view to what's coming up here with stage 3. There are two measures. There's a 1A and kind of 1B. For 1A, I talked about 50% being the current threshold. That moves up to 80%. And there again, it's just providing access, not actually measuring whether they're going in and doing the VDT. But for 1B, and I think this is a critical thing to know for stage 3 because it is helping us to kind of turn the corner a bit on the concept of the patient portal. Here it has API enabled to allow patient external access to their information from your certified EHR technology. Well, what's an API? It's an application programming interface. And basically, that is enabling your vendor to expose that information or make it accessible from an external entity or external piece of software. What kind of difference does that make? It actually makes a very large difference because currently, think of this scenario. You have a patient that's going to their primary care, and here they have user ID and login, and they're accessing their patient portal. However, then they go to a specialist. Maybe there's a hospital admit. Each one of these entities under the Meaningful Use program is required to have a patient portal. Well, inevitably where we want to get to is having a single patient portal where they can store their information. What the Stage 3 API does is enable them to make a choice and say that, you know, perhaps this particular primary care provider has an excellent portal. It will allow me to consolidate my information, and by having that API, they will be able to retrieve and include their information in one patient portal. So while not a question,
a question from the chat is, could you repeat again, what does API stand for?
API is Application Programming Interface, and that's kind of a techie propeller head term, if you will, but basically it's allowing access into your vendor's EHR system for that patient to retrieve their information. You may have heard of the concept, for example, like Blue Button, etc. Whatever that technology is, it's saying that somebody come from the outside in a secure manner and retrieve the patient information. So it's kind of a technical concept, but basically allowing access to information that has otherwise kind of been contained in a siloed environment. So I'm going to move on to secure electronic messaging. And here again, we see our screenshot of the specification sheet. And what exactly is a secure message? Well, we know it's kind of messaging back and forth between the patient and provider, but more specifically, it's a message whose content is encrypted and the integrity is protected. So again, kind of pointing to the patient portal, and if you were to look at the certification information for your EHR. There's some more detailed information on how that actually occurs. But for the end user, most commonly, that's going in and using something that looks very familiar, probably, again, like Gmail or Yahoo Mail, but, has send and receive capabilities, but it's just the fact that it's HIPAA compliant and going back and forth via that patient portal between the patient and provider. So for 2016, we need to send at least one message between the patient and provider. However, little caveat here, if it's patient initiated, the provider must respond to that. How do we know that the provider is responding? This is a conversation that you'd have to do or have with your vendor to kind of check with them and say, how are those counts actually being done when secure messaging is being utilized? Are we making sure that we're replying to that? Again, we kind of get back to the workflow issue. When a secure message is sent, do we have any standards or policies and procedures in place as to when those messages will be responded to? Again, there's the kind of certainty that a patient would need to know that if they've sent something that it will have some sort of reply within a certain time frame. In 2017...
And Reed, let me ask you just a quick question. Is there any requirement as to how quickly that response needs to be done?
No, there's no requirements in the CMS specification sheets. There's only the requirements or kind of the incumbency upon you, the provider organization, to do so within a reasonable time frame. And I'll get to a point about kind of the use of patient portals on the next slide, and I'll speak to that in a little bit more detail. So 2017, we know it moves up to 5% of unique patients doing that secure messaging. And then in stage 3, 2017, again, that's optional stage 3. In that particular year, we have the same 5% threshold there, whether you're doing modified stage 2 with optional stage 3. But then that jumps significantly in 2018 when we're required to do stage 3 to 25% actually sending that secure message, again, with disregard of whether it originates on behalf of the provider or the patient, but it's from the patient once again. It has to have a response from the provider. So kind of reiterating those points I was making on a prior slide, how is that counted? What is your workflow? What is the response time frame? Up to you. And another bullet point kind of going back to the same issues that we ran into with you download and transmit. There are going to be barriers there with elderly, non-English speaking populations, and we talked about some of the solutions there. One of the concepts I wanted to share with you, however, to effectively use your certified technology and patient portal is kind of that concept of a tipping point. In the conversations I've had with hospitals and clinics, that there seems to be this sort of critical mass of functionality that you're using in a patient portal. So we know we have to do as objective secure messaging and the view, download, transmit, and we know in future years that those percentages are going up. But along with that, there's many other pieces of functionality in a PHR, such as appointment requests, scheduling, prescription refills. Part of the VDT is going in and looking at your labs and so forth. But the more value that can be presented to the patient, certainly there's more draw to the PHR. And along with it, think about that concept of where are we going when we have that application programming interface. There may be some information that the patient is pulling out of yours into another PHR, but what are those things that are kind of native to your PHR that can help the patient utilize it better, so they may choose your PHR as the portal of choice is maybe one way to think about it.
Just one extra point, Reed. This is Lisa. And I did look in the specification sheet, and it says the patient-initiated message would only count towards the numerator if the provider responds to the patient. And then second, the action for the numerator must occur within the calendar year, but may occur before, during, or after the EHR reporting period if that period is less than one full calendar year.
Yeah, that's some excellent detail. And one of the things that we've gotten into in conversation with the vendors is we see this explicitly stated sometimes here. This is under so-called additional information in the specification sheets, but it is always good to have that conversation with the vendor to make sure that they've read this, interpreted it in a similar manner that you have, or if they haven't, make sure that what you're doing or how you're having those patients do a secure message, falls within that interpretation that your vendor has. So sometimes we do see the differences there, but
it's a good conversation to have nonetheless.
And one other point, the secure messaging objective is not required for hospitals, so they do not have an objective number 9.
Very good point. Thank you for mentioning that. So I'm going to hand it off to Lisa, and she has a lot to say about public health registries because there is indeed much to think about there.
And before we get over to that, Reed, one more question. In terms of tracking on this, I would highly suspect that you would suggest that organizations start asking or running reports on this on a regular basis to make sure that they're meeting that threshold so that they can look at workflow and look at capture. Is that true?
I think so. As we've had a number of meaningful use years behind us, we've kind of gotten into the habit of looking at those either meaningful use reports that have the percentages and are we hitting those thresholds, or the dashboards that are built into the system. So it's kind of that ongoing monitoring that I think most of us on the call, since we're a number of years into the program, are typically used to.
Okay. Thank you, Reed. So the electronic reporting to public health registries from certified EHR technology is the last measure we're going to be digging into, and probably the one with the most questions since the final rule has been released. For EPs, this is Objective 10 of 10 for eligible hospitals, and critical access hospitals, this is Objective 9 of 9. And the measures are a little different. The only difference is that the eligible hospitals have to report on 3 of 4 measures, and eligible providers on the 2 of the 3 measures. So really the only thing missing is this measure 4 from the EP specification sheet on this particular, and of course the wording is a little different. So this reiterates that the EP reports on either 2 measures or claims and exclusions, and the EH reports on 3 measures or claims and exclusions. And we'll talk a little bit about exclusions and alternate exclusions. But first, exclusions can apply for each measure, either regular or alternate. And it's important to note that exclusions don't count towards the total if another measure is possible for you to achieve. And alternate exclusions available in 2015 can apply for measures 2 and 3 in 2016 if you meet the criteria. This was just released the end of February in FAQ 14397. So they don't want to hold you responsible for something that you have to purchase into your system in order to meet these measures. So basically, you look at that FAQ, dig into the details, and determine whether you meet that exclusion or not. And if you remember, numbers 2 and 3 are syndromic surveillance and specialized registries. So this overviews the 2 regular exclusions available for EPs, EHs for all 4 measures. If you operate in a jurisdiction for which there is, for which information systems are either incapable of accepting the standards required to meet the certified EHR technology definition at the start of your reporting period, or they have not declared readiness to receive the data at the start of the reporting period. So for immunizations, the second exclusion, that's a regular exclusion. Oh, next page. For immunizations is if you do not administer immunizations. For syndromic surveillance, it's if you don't have an ER or urgent care department within your hospital for those hospitals and cause, or if you are in a category that does not collect data for syndromic surveillance. And then for specialized registry, the third measure, if you don't diagnose or treat conditions or provide data for collecting for specialized registries. And then for hospitals' reportable lab results, if you do not perform or order the reportable labs within your facility.
Lisa, we have a question in the chat where someone is asking can you explain, is it mandatory to transfer immunizations through EHR in order to meet this measure for MU Stage 2?
Yes, it is. I mean, and that is a specific, as it was before, stand by its own objective. So now it's included with the public health reporting objective, so you do need to have that immunization go to your public health immunization registry if your state does have one. I'll talk a little bit about what the states do have and the differences in a few slides down the road here. So what is active engagement? You know, they talk about you need to be in active engagement. And we'll address that question a little later. So the active engagement, there is good news and bad news about the three levels of active engagement. The good news is that the CMS has provided some slack and that you don't have to actually submit data to these registries. You are allowed to simply register with any of the 4 types of registries or be in testing and validation with them.
And Lisa, if I might interject here, one of the bad things is we're already beyond that 60-day threshold that's shown in the first bullet point under there. Basically, to be actively engaged, you could just complete registration with the registry of your choice, but that needs to occur within 60 days of starting the MU measurement period, and we know that we're beyond that threshold for 2016. So if you want to think about that for 2017, it's good to know. And then that second point, there needs to be a 30-day response from the organization that you contacted or registry to say basically, hey, we're ready to test with you and do some test submissions.
Correct. So, yep, that is the bad news. Beyond that
to be honest
period.
Here.
However, I think there are some FAQs that came out that, you know, what happens if, you know, we find a registry in the middle of the year, and you can use that for your period to register. And there's some FAQs at the end of this presentation that will address that. We may not have time to go through them all, but we have included them in your PowerPoint presentation.
So, Lisa, there's a question in the chat that talks about one of the participants saying that they have a problem with their practice is that the EHR has been trying to build an interface with state registry service, but they are still not able to make it. So is that where they would be in option 1 that they have?
I think at that point, if they have not been able to meet the other 2 measures, that this FAQ back on slide 27 addresses that. If you're not held accountable to obtain and implement new or additional systems, you could claim an alternate exclusion from certain public health reporting measures if you can't find other ones that you could meet.
So it isn't a matter of failing the measure, it's finding the appropriate exclusion.
Right, and also they are already in active engagement with that state registry.
I was wondering if that would be.
So I would think that they would meet that because they're in active engagement. Completed registration to submit data. And there are even remember what happened with immunizations, at least for Minnesota providers. It took a while for Minnesota to kind of get up to speed to accept your immunization registry. But you still met the measure because you were on a waiting list.
So one thing I might add to that, there's always this kind of conversation of what's the interpretation of the FAQ and the nuances there. And although I've already started, active engagement, completing the registration, and I'm not able to connect technically, does that mean I'm still in this testing and validation period? One thing I would add to that, wherever you fall, whether you claim the exclusion or you actively attest to that and say, yes, we're in that second phase, it's always good to retain some of this documentation of the conversations that have been going on and why you've claimed an exclusion. Anytime you claim an exclusion, it's good to keep that for your audit readiness file. We found that there has been turnover in organizations. There's a 6-year look-back period for the meaningful use audits, and it's always good to have a record of why a certain claim to an exclusion was made.
Excellent point, Reed, and yes, do keep documentation. Save it as PDF files, as we've always told you, so that it's not modifiable. On the day that you do it, put it in your meaningful use audit file even if it's just your scribble notes on a Word document, and save it for your audit files, that you've been in engagement with at least another registry or your state registry. So what does qualify as a registry? Hold on. There's a couple of questions here that we're going to kind of cover. Interesting. While there are standards for Stage 3 meaningful use, there are no standards for established for modified Stage 2. So you can either, I'm just going to explain this, it really isn't on here, but there's two different types of special registries. There's a clinical registry, which is a specialty organization type registry, and then there's a public health registry, which is generally run by your state, a registry that's run by the state, or if you want to call it blessed by the state, or whatever it is. And many of the registries that you might be mandated to report to might not even meet the criteria for a specialized registry. So if you're reporting, hospitals do this, I think, a lot more than providers, and maybe some providers as well. If you're already reporting to a registry, you want to check with that registry to see if they are set up to accept meaningful use registry reporting for public health. They'll tell you, you might need to email them. We've gone through some steps to find out which registries are and are not accepting, announcing them or declaring themselves as ready to accept data for meaningful use.
And I see there's a note in the chat box here. Vicki Haverkamp made a note, and we just wanted to share with you within the state of Minnesota that the reporting of newborn CCHD/EHDI results through MinScreen has been declared a public health specialized registry for meaningful use Stage 2 as of January 4th, 2016. So thank you for submitting that, Vicki.
Yes, thanks, Vicki, and that is a good point. And this is a great example of that. Minnesota, and this is only in Minnesota, has declared that as a registry for hospitals who have newborns. However, that was not published. They did not announce it until January 4th. So technically, you could take that exclusion for 2015 and even potentially for 2016 because they did not announce or declare their readiness until January 4th, which was not before your reporting period. But you can still use that registry. So as I said, what qualifies as a registry is they're planning to or currently accept electronic data submission. They don't have to actually be collecting that data submission, but they could be on the path to planning to meet the Stage 3 criteria. And declaring readiness. You really need to do your homework and go to at least one state registry and one specialized registry to see if they accept electronic submission by the beginning of your reporting period. In fact, for Stage 3, what they're saying is that the registries must declare 6 months prior to the reporting period to report for Stage 3, but those Stage 3 rules are subject to change. So another question, because the state of Minnesota does not have a way to collect currently, we do not need to worry about two. Yes, you do.
I think number 2 is the syndromic. Is that not?
Worry about.
Were they referring to syndromic measures?
Syndromic surveillance? Yes. And I'm just going to go over those in the next slide here. What are some other clinical registries? And in Minnesota, at least, we have the Minnesota community measurements that are considered a clinical registry. Not a public health registry, but Minnesota is aware of it, and Minnesota Community Measurements has declared themselves a specialized registry. And then for EPs and EHs, I'm going to go through this on the next slide, but they're listed here with the links embedded in them as the CDC's National Ambulatory Medical Care Survey and the CDC's National Hospital Care Survey have declared themselves as ready to, as meaningful use ready. Okay, a little wait here. So the public health registries by state, when you're doing your step 1, you check with your state. Minnesota's website is here, Wisconsin's website, and Michigan's website. And then there's just a little overview of the blue is the hospital applicable, and black is provider applicable. So this is the electronic registry, and as you get on the side, the syndromic surveillance, specialized registry for public health, and specialized registries, which are clinical data registries. If you step across, there's Michigan, Minnesota, and Wisconsin. There's a question on the chat. Does Minnesota Prescription Drug Monitoring Program count as a specialized registry? No. We've checked with them, and they're getting lots of calls to ask them that, even though it's addressed in an FAQ that your PDMP might be a specialized registry. And the reason is because most especially provider clinics, you have to actually report this as to the state, to the Prescription Drug Monitoring Program, and the Minnesota PDMP is set up for pharmacies to do that, not for providers to do that at this point. That doesn't mean they may set it up in the future. They have not answered that question. They said it could be a possibility, but they don't want to jump to that boat until they know CMS is going to, stick to their guns on it. Just one of these FAQs, and what time do we have? We have about 7 minutes remaining, and I want to save a little time for question and answer. But I'm just going to explain, we have several of these Q&As. What steps does the provider have to take to determine if there's a specialized registry available to them, or if they should claim an exclusion? And the EPs are not required to make an exhaustive search of all potential registries. Instead, they must do a few steps to meet the due diligence of determining, and that includes checking with your state, as I mentioned, to determine if there's specialized registries, and the EP should check with any specialty society with which they're affiliated to determine if the society maintains a specialized registry. And the next FAQ kind of talks about that. What does the hospital need to do? You don't have to do an exhaustive search, basically. If no organization exists in your jurisdiction, has no registry, you can simply exclude from the measure. However, I did show you in the slides, a couple of slides before, that there are some for hospitals available. And with that, I'm not going to go through the rest of the FAQs. You can read through them at your own leisure on your, what can count as a specialized registry. So we could have a few minutes at least for Q&A.
Well, excuse me, someone in the chat had again asked where the materials are for this. As you log into the presentation, the materials, both the Excel file that Lisa talked about at the beginning, the PowerPoint is available at that point. There's another question on the chat for both of our presenters. Talks about Genesis Registry for Physicians. Have you heard of this? Are other people using it?
I've not heard of that. I apologize, but we can take that offline and do a little research and see what that registry is about.
No, I have not heard of it either. And again, there are so many registries. When I started doing the search, it's an exhaustive search that I did. There are many, many registries. You have to check with that registry in specific to see if they are declaring themselves as meaningful use ready.
And I would kind of circle back to that concept that Lisa was explaining in that FAQ. It's basically the due diligence. What are you responsible for as far as locating a registry that's applicable to your practice area? And number one is looking at the state level, finding out what's available. And number two, going to your primary or specialty care organization, could be a national level, and making an inquiry with them there. As you read the FAQ, it says basically, and maybe Lisa, you might even be able to quote this, you've looked at it a few times, that you don't have to do an exhaustive search. It's just basically you're doing a best effort type search to locate a registry.
Yeah, and please do look at those. When you do get the presentation, look at those last FAQs, and it does address those all in detail. We just didn't have enough time to go over all of them in detail. There's a question on the board about the future. Sorry, I'm going to have to get over. Regarding how does MIPS and MIPS affect EPs and EHs? We don't know until they publish the proposed rule, which they need to do by May 1st. We're hoping that sometime in April that proposed rule for MIPS will be, and yes, it does affect EPs in that, the EHR incentive program and the PQRS and value-based modifier, along with clinical practice improvement, are all going to be scored and give you a score of, 25 to 30 percentage points they each. I'm just taking that off the top of my head because I don't remember the exact percentages each of those four measures carry, but it weights it, and you do, then they roll that into the MIPS plan, which will then affect how your payments are adjusted on Medicare fee-for-service or physician fee schedule beginning in 2019.
I was going to add to that. That was what I was referring to earlier as the composite score, where Lisa was explaining the weighting depending on which of the four components kind of roll into that MIPS formula. And ultimately, the difference between the MIPS track and the APM track from a payment perspective is the APM alternative payment model would give you a 5% payment bonus in years going forward. We may see modifications to that. We always kind of have to say there's a little bit of a caveat there. But on the MIPS track, that can be a plus-minus percentage. So you might have a positive, neutral, or negative payment adjustment, and that increases as the years go forward, and that is based upon your composite score.
And just as an aside, we as LS Quinn will be having webinars and educational and training sessions on MIPS NACRA as all of this starts to unfold over the next couple of years, as well as our understanding that CMS will be having some more individualized training and presentations too. Yeah. So I know we're running right down to the end of our time here. It's just a couple of minutes.
So we've got a few questions that are out there. One thing is we were talking about this future thinking, and I wanted to insert one more comment going back to the HIE objective and measure. As we get into stage 3 for 2017-2018, that's another area to do some thinking on, and just be aware of what's coming on the horizon if you do intend to stay on that MIPS track with meaningful use. One thing I wanted to mention there was HIE, that transition to care, summary of care document, where the threshold was 10%. In stage 3, if you're doing it optionally in 2017, that moves up to 50%, and then that will become mandatory in 2018. And along with that, there's a requirement, and now this is where we get into multiple measures, of having a 40% threshold for transitions that are outbound. And then if you have information that's coming in, for example, like a CCD, there's something new. Lisa was talking about medication reconciliation. There's a new concept, which is basically clinical information reconciliation. So as you absorb that CCD into your system, you need to make sure that you're questioning it and making sure that that CCD information is accurate. But just some future thoughts for the Meaningful Use program.
So I'll tackle the last question in regards to the e-prescribing for hospitals. Yes, you can take an alternate exclusion if you are scheduled for stage 1 in 2016. If you were scheduled for stage 2, you cannot take that exclusion, that alternate exclusion.
Okay. All right, everyone. I know we were right at the top of the hour. I want to thank our presenters for an excellent presentation with still more questions to come. Thank you, Reed. Thank you, Dr. Gall. At the end of the webinar, you will be dropped off at a link for an evaluation of today's presentation. We highly encourage you to complete it and answer and recommend other areas that you would like to hear and learn more about that we can think about offering in the future. If you do have additional questions, there are names of the contact within each of your states. Please forward those, and we get together as a group on a regular basis to look at what we have for questions and respond to the community as a whole. So again, thank you very much, and have a good day.
Thank you. This does conclude today's teleconference. We thank you for your participation. You may disconnect your lines at this time.